So I was so glad that you sent us this article about Lacanian interpretations of psychedelic experience, which honestly, I didn't even know was a kind of article that you could write. And I was particularly excited about it because it intersected with a story of a famous philosophical psychedelic trip, which I learned about in grad school. Jean-Paul Sartre famously was followed around by, in this text, it says crabs. I always learned that it was lobsters after this mescaline trip. And like for decades, he would be like walking down the street and would say to Simone de Beauvoir, like, oh, there's a lobster following me. But so in this piece, which is by Timmy Davis, and it's called New, Strange, Odd, and Weird Perceptions, a Lacanian Account of Psychedelic Experience, Davis writes, I believe that Lacan must have had some exposure to the effects of these substances outside of fear-mongering and sensationalist reporting. While I have been unable to find evidence of his own ingestion of a psychedelic substance, he did analyze Jean-Paul Sartre, who had persisting hallucinations of being pursued by crabs following a mescaline trip administered by Daniel Lagache at St. Anne's Hospital in 1935. Sartre says that in his analysis with Lacan, the crabs were interpreted as indicating a fear of becoming alone with which he had struggled for some time, a sentiment that certainly informed his philosophical imagination. Of all of the conversations for which I would have liked to be a fly on the wall, Jean-Paul Sartre telling Lacan about his lobster or crab hallucinations and his fear of loneliness, like that just like went to the absolute top of my list.
That would be amazing to be a fly on the wall in that room and see what they're talking about with a French translator. For me, maybe not for both of you, but yeah, I didn't realize there were all these intersections and people in similar circles that were interacting with each other during this time.
I was putting together a sort of informal list, and I had Benjamin had some mescaline administered at some point, as did Merleau-Ponty, and a variety of these other sort of French figures. And Sartre at least has this statement that feels sort of psychodynamically, or at least, maybe even psychoanalytically pregnant about the experience, where he says, the crabs really began when my adolescence ended. So
Jesus Christ.
It's coded as something. The Benjamin material I was able to find is a little more chaotic. He had friends who actually, they had him do Rorschach tests while he was taking mescaline, et cetera. And he apparently solved the mystery of a children's book about like a boogeyman. And his takeaway was that the lesson of the children's book is that children must be given gifts, otherwise they will die or be eaten by the boogeyman. Right. Which again, I guess, these all have kind of dark.
Checks out.
Yeah. But with Sartre, I mean, there is some indication that he's got a crab thing. There's some play, one of his plays, there's like a crab god that passes judgment on humanity. But I learned it as a lobster.
Yeah.
Yeah.
I think from Simone de Beauvoir.
We'll split the difference and call it like a langoustine. It's like a big, delicious kind of like prawn thing coming at him. But that also doesn't sound like something mescaline would do to you. I feel like there's some amphetamine psychosis or something else going on there. Just I don't know. As a story, I don't buy it.
It doesn't sound like an incredibly rich therapeutic session.
No, and sort of symbolically, I'm thinking of this idea, as well as you're talking, Patrick, of this thing called in evolutionary form carcinization, of convergent evolution, where over time all things lead to crab, like the final common pathway.
Squat and chitinous and eating dead animals that sink slowly to the bottom of the ocean.
The perfect form.
At the end of H.G. Wells' Time Machine, when he goes to the far future and the sun is dying, all that remains are these sort of like crab
people.
Yeah.
Crab people, crab people.
You're listening to Ordinary Unhappiness, a podcast about psychoanalysis, politics, pop culture, and the ways we suffer now. I'm Abby Kluchin.
I'm Patrick Blanchfield.
And today I am so pleased to introduce Dr. Josh West. Josh is a medical doctor and psychiatrist in training based out of Melbourne, Australia. Thoroughly Freud-pilled, he has pursued further subspecialty training in psychotherapy, which has led to being involved as a therapist in emerging clinical trials coming out of Melbourne, looking at psychedelic-assisted psychotherapy. Josh, welcome to the show. Thank you so much for being here, especially at 7 a.m. Melbourne time on a Saturday morning. We owe you big for that one.
Good morning. Thank you for having me.
So let's get into it. Can you tell us a little bit about your background and about how you came to be involved in psilocybin-assisted psychotherapy clinical trials?
Sure. I was thinking about this. I had to go through all of my emails and find out how did this actually happen. And it was similar to me being on this podcast. It was from a series of interactions and me putting up my hand to participate in things I'm in no way qualified for, I think. So I thoroughly Freud-pilled. I was lucky that early in my psychiatry training, I think similar to in America, the first year is really based in inpatient. You're dealing with really severe mental illness, treatment-resistant schizophrenia, and you're learning about all of these biological agents that we use as our last line of defense, things like clozapine. And that's like expected knowledge early on. And I think I was lucky that back then, as I was learning about things like clozapine and getting my foot in psychiatry, I also had this supervisor that was from day one teaching me about Melanie Klein. So I knew as much about Klein by the end of first year as I did about clozapine. And that was great for my foundation training and sort of put me on this path to, I need to know more about psychotherapy. There is not enough in this training program for me. I can see I need to go further. So I tacked on some advanced training in psychotherapy along with my general psychiatry training in Australia. And part of that involved these weekly seminars with a cohort of us that were similarly psychotherapy inclined. And this is probably going back to about 2023. And then at the end of it, we all got an invitation to go to a local hospital in Melbourne. And we were invited to see the work that Justin Dwyer and Marg Ross were doing out of St. Vincent's. And all I knew then was they were giving psilocybin to end-of-life care patients that were in palliative care. And I thought, yeah, all right, why not? That'll be interesting. And that's all I sort of knew. There were some headlines about it and the media had picked it up. And I go there and I meet with Justin and Marg, and they take us into their rooms there, and they've got this dose day room that they've set up to be beautiful and has all this mood lighting. And they tell us how they did this. They said it was the first clinical trial for psychedelic-assisted psychotherapy that was ever approved in Australia, I think possibly the Southern Hemisphere. At that time, they had treated about 35 patients, and they're looking at easing, end-of-life distress and anxiety and depression associated with this population with a terminal illness, and talking us through how they figured out how to do this work together and to work as this therapeutic dyad and to deliver this care and what it would involve, what the room needs to look like, what music needs to be played, how they actually navigate trying to work therapeutically with someone that's under the effect of these powerful substances and how they create some sort of meaning for them. And as they're talking, I'm starting to get this sense that this is not a drug trial. This is a psychotherapy. And then it just sort of blew my mind. I realized they are on the forefront of something very, very new. They had this deep respect for the work. And I came away from this sense that it is not writing a script and giving someone psilocybin. It is giving them this drug to facilitate a tremendous amount of therapeutic gains very, very quickly. And the outcomes for the participants, we got to see some recordings of them, were phenomenal. These are people that were struggling with a lot of existential despair and difficulties navigating, the end of life process and getting their affairs in order and confronting, living with an illness that they know is going to kill them. And all of the associated difficulties that come with that emotionally, and thinking about how they'll, how their family are going to be taken care of, and this sort of paralysis. And then seeing and hearing stories of people that have gone through this treatment and then can go towards death with an openness and a curiosity, and to be able to do these things that there was this block that they couldn't approach, they couldn't do their will, they couldn't put their affairs in order, that now suddenly they can, and they can actually spend their last days actually living and not just existing, but laughing and participating and being present again. That just, it blew my mind, and I could not stop thinking about it. So I just hassled them. I sent them all these emails, and I had so many follow-up questions. And then one thing led to another, and I got invited to participate in some training for an even bigger study. They said basically on the tail of their success of treating about 35 people, that there was going to be a bigger one looking at using psilocybin for treatment-resistant depression across multi-sites in Australia. And would I like to come along and be trained as one of the therapists? So I thought, why not? I'll see how that goes. And then I turned up to this 4-day, very intense, like 10-hour a day training session run by Justin and Marg. And that was a lot. That was, they said it was going to be very experiential. I had no idea what to expect. I thought, are we going to go picking mushrooms together? Like, what the hell have I signed up for? But it was at a university, and they set it up like a dose day for a psychedelic psychotherapy session. It was all very soft lighting. They had all these projectors and galaxy lights and all this very, sort of ethereal, sort of binaural music playing all the time. We were on yoga mats. And this is how we're doing the training. So it's a very floaty, sort of dreamlike space that we're learning in. And it was, these 4 days of trying to practice working as therapists in that setting, which without the drug is already intoxicating and feels like you're in this floaty space.
Yeah.
So it was about, trying to hold that therapeutic position still despite all of this going on around you. Trying to not get swept up in the setting that's happening for it. It was really, really interesting and really challenging to do, actually. And we would go through these sort of like practice sessions, like they would show us, like, here are a few things that have happened during our dose days, and how would you navigate it, and pair up and try and attend to this challenge that might emerge. And all this time we're learning from their experience of the participants they've treated, and we're looking at these recordings that they've done of their trials, and trying to talk amongst ourselves how we would approach these difficult situations. And a lot of it was from this one participant, Lindy, who they had told us a lot about, who we got to watch hours and hours of footage of during this training. And Lindy was someone that was featured on a small documentary that was made about Justin and Marg's work in Australia. So she became a very familiar face. And then on the final day, as we're sort of wrapping up and talking about where to from here, Lindy actually turned up.
Oh, wow.
And sat in with us. And gave us sort of her words of wisdom and what she wants us to know as like the next wave of practitioners and what she found really helpful. It was incredibly emotional. All of us were crying, and it was this moment where it was like, oh God, okay, all right, this is what I'm doing with my life. All right. It was incredibly powerful, and just the most mind-blowing training experience I've ever had. And that was my introduction into working in this space.
That's just phenomenal. And what I'm so struck by listening to you and looking over the materials that you've made available to us is how, to paraphrase you and hopefully not too clumsily, for you, the question of psilocybin as a substance is not isolatable as like a clinical drug trial, but as you say, it's about an entire treatment orientation as a treatment modality. It's a way, and I'm reaching for, I guess, the language of like the transferential constellation. It's a way about producing an entire environment, an entire approach to administer this. And thus it's something other than just, the double-blind drug trial that is going to give you the next generation of, what, today you're taking escitalopram every morning. In 2 years, you're going to take some sort of, mushroom-based pill. It's instead an entire sort of full-bore engagement of both the patient, but also the clinician, and in a mode that, as you say, is oriented towards, and it's a lovely phrase, living, not just existing.
Yeah,
and
I was struck by that too.
And I think that's clearly about doing something other than making someone more tractable the way you might by, heavily dosing someone on some sort of antipsychotic in an inpatient's context, or just making it so that they can bang out that last will and testament without falling apart. But actually it's about them too, in addition to the people around them in that way. And that something about that feels humane and not narrowly targeted, or like not simply about a technology. It's an entire approach, it seems.
Yeah, that's exactly it. It's the psychotherapy is inseparable from the drug. It's a difficult thing to think about. I guess for me, like I've been doing a little bit of work in these trials. I've done one trial, and there's another one coming up, and there's a lot of talk about the different formulation of the drug and sort of, or maybe the delivery mechanism for it. And understandably, from the biotech companies that produce these, like that's what they're sort of selling, and this is the important. It's like their particular formulation of the psilocybin and how it gets absorbed, either orally or IV or things like that. And while that is interesting in a way, from where I'm sitting, thinking you can't really separate it from the therapy, and that the drug is actually just a way of amplifying the psychotherapy and facilitating something, and that it all considers the set and the setting and all of the things that are wrapped up in it, including people's expectations of what this is going to do for them. These sort of feel like they're a psychotherapy trial that's masquerading as a drug trial.
Yeah. Before we get more into the clinical encounter, can we zoom out a little bit? Do you mind, Josh, if I ask you to do a little history lesson for our listeners? Because I think a lot of folks have a sense that psychedelic assisted psychotherapy is poised to become like the next big thing for treating so many forms of mental illness. But what's actually going on, like the state of the research, legal status, et cetera, it's kind of a black box for anyone who's not up close the way that you are. So do you think you could give our listeners a little bit of a snapshot of the history of psychedelic research and what's now being called the quote unquote psychedelic renaissance?
Yeah, sure. There's sort of two different stories about this, and I've had to do my own reading into it. So my experience is only in using psilocybin. So I've had to learn a little bit about that history, the way that a lot of people think about how these entered the treatment space and how it entered psychotherapy. A lot of people go back to Albert Hoffman, who was a Swiss chemist, and this sort of serendipitous discovery of LSD. He was a chemist. He was looking into some ergoalkaloids. He accidentally synthesized it for the first time in 1938. And he was contracted. He was trying to look for basically this like circulatory and respiratory stimulant that would spare the uterus to be used in certain cases. And he created it, left on a shelf, forgot about it for 5 years. And then, the birth date, I think it was April 16th, 1943. He was looking at some of the compounds that he's made, and he accidentally gets some on his skin. And he had this sort of profound experience. He described it as I've got his quote here: affected by a remarkable restlessness, a slight dizziness at home, I lay down and sank into a not unpleasant, intoxicated-like condition characterized by an extremely stimulated imagination. In a dreamlike state with eyes closed, because I found the daylight unpleasantly glaring, I perceived an uninterrupted stream of fantastic pictures, extraordinary shapes with intense kaleidoscopic play of colors. So, like any good scientist, he tries that again. He comes back a few days later and he goes, I'm going to, intentionally take some now. So he took what he thought was like a prudently safe dose of 250 micrograms of LSD, which for any other drug, I mean, that's a quarter of a milligram.
Yeah.
You'd think you're pretty okay. But for anyone that knows anything, 250 micrograms of pure LSD is quite a lot. And then he got on his bike and tried to ride home.
This is what they call bicycle day, right?
That's what they call bicycle day, yeah. And, people were morphing into fantastic creatures. Office furniture was shifting. He felt possessed by otherworldly forces. It was disorienting and overwhelming. So that was the first intentional LSD trip in history, I suppose, bicycle day. So from that sort of sparked this interest in how could we use this among researchers and therapists in like psychiatric applications. If we think about it, we're going back to 1943 or even 1950s. Like our first antipsychotic, that didn't come about until 1954. So until then, we didn't have any real agents in psychiatry that were biological other than maybe ECT. And all of the institutions were run by psychoanalysts. Those were the only tools that we had. So there was this sudden interest in using it for different purposes. I think the 1960s, you get this explosion. There are like over 700 publications discussing how it could be used. And it was thought that you could use these for people that previously were sort of unanalyzable. Like, what about people that you can't treat by classical psychoanalytic means? It has promise in treating conditions like alcoholism and psychological relief for terminal cancer patients. And then also, sort of from the work of Stanislav Groth and Timothy Leary, they were looking at, you could like probably use these to get pretty profound and rapid changes to like fundamental personality structure. Like there's something about these agents that seem to quicken the therapeutic process in people that otherwise would take a much longer time to get there, or that they can be used in populations that we thought couldn't be treated by these typical means. So that's sort of how that happened. And then it sort of famously like sort of escaped the lab. It became sort of associated with the counterculture movement. People were using it recreationally. I think there's something about it that really was seen as a real threat to the administration at the time. I think I'm sort of stepping on Patrick's toes a little bit here about American history. I've had to, this is not my forte, but just this idea of I think you have a lot of people taking this. It's going to get people to challenge maybe existing power structures, or think about, this anti-authoritarian stance, or critically reflect on what's going on in society and the direction the government's going. So that sort of got really shut down by Nixon, and his war on drugs, the passage of the Controlled Substances Act, and then the creation of what became the DEA. And that sort of classified LSD and any other psychedelic as Schedule 1 substances, higher potential for abuse with no accepted medical use. And then, basically all these studies just shut down basically immediately, and scientific progress halted. The rest of the world followed suit, and we had this sort of, clamping down. Nothing happened. And then the resurgence sort of came from, the 1990s. That's when they started looking into basic safety and the psychopharmacology again. Then some more clinical trials start to emerge in the 2000s. They start trying it on specific conditions like PTSD. Some landmark studies that came out of Johns Hopkins and Imperial College London. And then we start seeing like these can be taken safely. They seem to be at least non-inferior to the existing treatments we have. And they show some promise. And then it sort of went from there. Now we've got quite a lot of trials for psilocybin, at least, happening across the world.
I just want to pause for 1 second, just imagine what was going on inside Albert Hoffman's mind when that first time, but then that second time, just without having anyone else there to be like, don't worry, this is only going to last so long, or like, I'm still here. Having no one to trip sit him but his own bicycle is that a lot of very maybe Swiss composure was at play in that. But it gives this image of like the nutty professor, as it were, in his lab doing this thing, and then it becomes it's this thing that could be dissolved in the water supply, or that you could be dosed with by blotter paper or by the CIA, right? It both has this very sort of technical scientific genealogy, and then has all these narratives that map on to broader anxieties about like the fragmentation of a shared universe or reality under like postmodern conditions. But then at the same time too, there are other drugs, right? And I think psilocybin being one of these key examples, namely, well, it didn't take a Swiss guy in a lab to accidentally discover those, and they're not the thing that you need to sort of synthesize with a whole series of, whether you're in an underground laboratory somewhere, in the Badlands, or you are a Swiss pharmaceutical firm. These are literally growing in the earth. And could you tell us a little about the history of that and how that enters sort of the Western research apparatus and exists within it?
That's a good point. And I think the way that I described it, like that's a very sort of linear and like very nice and neat way that is excluding a lot of information and tells this sort of story of this nutty professor in a lab that serendipitously, through his own accidental genius, comes across this thing. And now, oh my gosh, look at these applications. Look at where we came from and where we are now. How crazy. What a story. What a fun story to tell. And that's one section of the history of psychedelics. And it's a very Western centric view of psychedelics. One of ours stumbled across this through his ingenuity and tenacity after holding on to it for 5 years, and look at these amazing discoveries. This titan of industry. Look, that's fantastic. What it's excluding, I think, and I'm glad you mentioned it. We asked beforehand. I'm like, I'm in two minds. I feel like I want to sell this side of the story as well. It's completely neglecting some of the other origins here at play, which is that, psychedelics, as they are found in nature, in plants, in mushrooms, these exist in the natural world, and these have been used for ceremonial and ritual purposes by indigenous cultures for thousands of years. And they have been the custodians of these medicines and the holders of this knowledge and this wisdom. So in a way, it was not Albert Hoffman that discovered something for the first time. Like, this is almost being repurposed. And I think that the story of psilocybin is a lot darker. It basically emerged after Hoffman in 1943. We're going to the 50s now. And we get basically this person, his name was Gordon Wasson. He was a JP Morgan banker of all jobs, which is just chef's kiss for this story. And he was an amateur mycologist, apparently, along with his wife. And he had heard about that there are some places in Mexico, Mazatec communities, that were using mushrooms for ceremonial religious purposes that had some sort of properties to them that he thought was very interesting. So he went to Oaxaca and he found this Mazatec medicine woman whose name was Maria Sabina. And this was one of the few remaining places that would use these psilocybin mushrooms in religious ceremony and revere them and have deep respect for them for these ceremonial and ritualistic purposes. Previously, from what I understand, it was a lot more widespread, but with the Spanish colonists and the Catholic Church, they really wanted to stamp out a lot of these practices, and this was like one of the few remaining places that were doing it in this community. And Maria Sabina was really held to high regard as an important person in her community, as this holder of knowledge and of wisdom, and really deeply respected. And these were the first, white people that came to see her and to see these ceremonies. And they really pressured her to allow them to even attend and to witness. And I think she was pretty uncomfortable about it, but ended up allowing it to happen. And then it became this process of pushing for more and more access to this. They ended up participating in one of these ceremonies and taking the mushrooms. I think it was largely through some deception. They told her that they needed to get access to these visions to be able to guarantee the safety of someone that they said they had lost on their trip. So that's how it sort of started. And if it couldn't be any worse, afterwards they returned to America, and really all she wanted was like, please keep this to yourself.
Yeah.
Don't, expose me or make a big deal of it or identify me in any way. Like, I was largely uncomfortable with this sort of how this unfolded. So they go back to America, and he publishes in Life magazine in 1956 an account of his experiences. It is not just an account of an experience. It is, he names the village. He names Maria Sabina. He includes a photograph of her, all against her wishes. And then you suddenly start getting these busloads of tourists and hippies on pilgrimages to this place to go through this process. You get George Harrison, you get everyone coming over time. And this town just could not support these hordes of outsiders invading and demanding access to these sacred mushrooms, and either not knowing that they need to be respected and used in a certain way, or not really caring, actually. There was no respect for ceremony. And what happened is in her later years, Maria Sabina, she came to really regret that she actually shared this with these Westerners. It was horrific and absolutely tragic. Her house got burnt down. She was exiled from this community. Her son was, I think, thrown in jail and possibly murdered later on. And she ended up dying as a homeless woman. These colonizers coming in, sort of like forcing, give us the fruits of your indigenous labor. Like, we demand it. We see a need for it. So give it to us at what cost and what expense. Well, we saw what happened. And so that's the story of psilocybin, which is much darker and something that I think I try and hold in mind in doing this particular work.
Yeah. If I recall the story correctly, that Life article is also the source of the phrase magic mushrooms, that was in the title. You have on the one hand the story of Maria Sabina, who is this respected elder who, because of this interaction, not only are her wishes disrespected, but her life is essentially ruined by this decision. But that is the production of this new recreational drug in the West. I want to point out this shift from the ritual and religious context to this idea of magic.
Yeah, and magic, particularly in the sense of it being this kind of ancient but underexploited or underdeveloped resource, which can then be integrated into, well, individual Westerners' journeys to always discover themselves, but that also means just like as a site of exploitation. And I'm thinking here of Andrei Znamensky's really lovely recent book, The Beauty of the Primitive, Shamanism in the Western Imagination, which has a sort of a history of this concept of like the magic healer or the medicine person or the medicine man is the phrase is sometimes used, but specifically has several chapters on the allure of primitive peoples having this sort of quote unquote knowledge, which is always on the one hand ascribed to them and made sort of timeless and eternal, precisely insofar as it can then kind of be wrenched from context and differences between different traditions sort of liquidated. And I think there's a line that Zemensky has quoting Maria Sabina after, I don't know, the cat is out of the bag, right? And people like, like Dennis Hopper and is traveling down to Mexico to meet her and all this stuff. And I think it's a haunting line, but something to the effect that the mushrooms are no longer talking to her and they don't have anything to say anymore. They can't sing because other people are crowding it somehow. And what I find so striking in some ways, as you tell these two stories of, the LSD and psilocybin,
like the triumphal LSD narrative next to this really dark story of,
or they seem to be kind of mirrors in some way, in the sense that, well, here's this thing called science, which produces this substance, and this substance cracks open minds. And then here is this other sort of undifferentiated indigenous other, and they have truth, and that can now become mined by science. And in both cases, there's a kind of neglect or erasure of like relational differentials in power, but even just like the relational component of people and their needs and their vulnerabilities and where they're at in different places in time.
Yeah. Yeah. It comes back to that idea of like, these are a sort of psychotherapy, a relational psychotherapy trial masquerading as a drug trial. It's this thing of like, the origin of where this came from, like the psilocybin compound itself, like it came from this living thing that, these cultures and these people had seen it as something that they nourish and they tend to, and they are the holders of and the custodians of. And these are a thing that facilitates connection. It's worthy of a respect, some sort of irreverence or love even. And it's sort of like, how do we extract something from that? How do we turn that into this sort of object, like a pill that we can then take and just pull out all the valuable stuff out of. And I think the thing is like, these are, this sort of ties in with like the set and the setting when we get into what psychedelic therapy actually looks like and the expectations that people bring along with it. This is all part and parcel, because I think that the main thing here is that the power of these substances, it's not that they specifically change chemicals in our mind, but they change our relationship to ourselves and the world around us. It's all wrapped up in that story and that narrative and that meaning-making experience.
Trying not to romanticize in a sort of naive way indigenous sort of life ways, which we know are not static and they change and they're very sophisticated, right? But there is this, and there's so much diversity between them, and many scholars will question, like, you know, the universality of a thing called shamanism across cultures, right?
Yeah.
And then you also have figures in the Western tradition who'll be like, well, actually, I've developed, like Michael Harner, I think, is the guy who has this core shamanism, where he's like, I've taken all the shaman traditions in the world and I've removed all the things that make them like different. And this is the core set. You can become a core shaman, and that involves drumming, and you can do that in your backyard. And it's very, well, it's very a la carte in some ways. But it's also presented as having a type of rigor in the way in which, like, I can draw this molecule on a board for you, right? Or I can make this into an aerosol. It's a technology, it's a commodity, and the running through line seems to be, it's a product that produces something for you as a self, right? It's about your self-realization, it's about your self-actualization, it's about your own self journey of, like, let's call it like healing. It's not necessarily relational.
So, Patrick, you're giving me a good segue, because I do want to return to the relational context and specifically, Josh, to ask you about your work, about what it looks like to be a therapist in psilocybin-assisted psychotherapy. So can we get real granular about this?
Yeah.
I mean, I want to ask like a couple of questions, and, you know, take these in whatever direction you want, but what is it like to guide a patient through a psychedelic session? How do you prepare yourself? How do you prepare the patient? What is the process of integration like after the dose day itself? And how is this both similar to and different from what we think of as more, you know, standard or normal or traditional or whatever you want to call it, talk therapy?
I will go into it as much as I possibly can.
That
I'd love
sounds
to.
like exactly what we want.
Yeah, it's very, very different. I didn't know what to expect, and I've had to unlearn or relearn a lot of assumptions what I thought about therapy was. In general, for these sort of trials or these, you know, psychedelic therapies, generally they are split into 3 different phases of treatment, which involve a certain amount of time spent on preparation. Then you have a dose day session. And then following the dose day, you have integration of the experiences of the dose. And that can be more than one session. It can go on ongoing. You can have repeated dose days, but it follows that sort of process. I think what's unique about this sort of treatment as a therapy is that, at least in the contemporary trials, it's sort of been accepted that the way that this needs to occur with a participant is that it is a treatment that's delivered by a therapy dyad. So it is a pair of therapists, which in itself is is new. It was new for me. It's new for a lot of people that do it. And it's something that really, I think, is where a lot of my thinking and new experiences came from. It came from working and delivering therapy with another right next to you and working together and stumbling through things and being a bit weird with each other and not knowing what the other one's supposed to say or where they're getting at, and learning how to work together there. And it's sort of it becomes like more than the sum of its parts. It's sort of not just this, it's not like co-therapists with one participant, it ends up being this dynamic that gets wrapped up all together. The expansion of this sort of therapeutic boundary is not just you and the participant and your co-therapist and the participant, like it's all inclusive. And when things start to go wrong or right, you also observe that reflected in the relationship of the dyad and in the dynamics there. It's very, very interesting. I always thought it would be cool to be a fly on the wall to someone's sort of therapy, because when it's just you as the therapist and a participant, you're sort of thinking like, oh, countertransference, or like, oh, is that a lot of projections happening there? I don't know, because I'm both the experiencer and I'm the observer. Now you get to be the third, and you can actually see some of these things happening, which is really interesting to be privy to, because you can come away from a session and both of you speak afterwards and have completely different experiences of what went on in that 1 hour together. And through that, you can sort of try and get an understanding of what could be going on for this person in front of you. So the biggest challenge has been, or the biggest difference has been, to start with just working in a dyad with another therapist that you have to be completely open with, very vulnerable. You have to have deep trust with, and to be able to say uncomfortable things and share parts of yourself that you necessarily wouldn't.
So I had a question or two about the dyad structure.
Yep.
Are the two therapists ideally or normally supposed to have different clinical backgrounds or orientations? And also, do they have equal amounts of previous experience with the patient in question? Or is one of them just coming in sort of for the first time? And how does that relate to their sort of meetings between the two of them when they're not seeing the patient?
Um, the recommendations, and this is all very, very new stuff.
Mhm.
We're like building the plane as we're flying in
Sure.
here,
Yeah.
I think, across the world. But at least, in Australia, our College of Psychiatry, they've made some recommendations of what are the like necessary and essential ingredients to do this sort of safely. And they endorse working in a therapy dyad, so two therapists at any given stage. One of those reasons is for safety reasons. We'll get into later, but just to make sure that nothing untoward happens and that everyone's accountable for what happens in the room when someone is in an intoxicated state.
Mm-hmm.
The other one is they recommend that one of them, in terms of their background and their training, be typically medically trained.
Mm.
And the other one being some other sort of training where they're skilled in psychotherapy, so social work or OT or psychology, typically psychologists. So you usually have one member of the dyad is medically trained, and the other one is more of a typical psychological background and training. At least for now, for the reasons that they're doing it for the trials, is that these are highly controlled substances and medications that need to be both prescribed by someone to get access to, and there's some degree of physical health monitoring involved as well. So that's, I think, the justification for why at least one person in this process needs to have some sort of medical training and background. But interestingly, the makeup of the dyad and the relative experience and things like that, I can tell you from my experience in the dyad that I'm working in, it's been male and female. That has been a typical sort of dynamic that is replicated among a lot of studies.
Interesting.
I think that's an interesting one in itself. You pair mum and dad together, and then you just allow them to project as much as they want. My therapy dyad partner has been a really good fit for me. She is a bit more experienced than I am, is a psychologist, is female, and comes from a very, I think, different sort of orientation. She's very emotion focused sort of psychotherapy, and I think I'm from a more psychodynamic perspective. And there's something about that's worked really, really well. We found our groove, I think.
And are you only ever meeting with the patient as a group of three, or do you have pre-existing relations sort of differentially with the patient?
Only together.
Okay.
No previous relationships. There might be a bit of a screening process beforehand with the trial where my partner Claire meets them a few times before I do. But really, it's when we meet, whenever we do any sort of therapeutic work, it is as this sort of united front, this therapy dyad, from the preparation to the dose day to the integration.
So can you walk us through? So you're working in a dyad, which I mean, I'm going to have to be thinking about this. So I mean, it really changes so many things about just the therapeutic encounter to have this sort of triangle.
Yeah.
But okay, so that's so different. Can you walk us through preparation, dose day, integration?
Yeah, sure. And you're right, it makes your head spin. Once you realize there's like three people in the room, two of them are therapists, and they're working as this sort of symbiotic like dyad, it's already your head sort of spinning as to like what could be going on in that room, and the splitting and the projections and all of that. It's really hard to keep track of.
I mean, I thought co-teaching was complicated, but that's nothing compared.
So I think of those three phases. You've got the preparation, the dose day session, and the integration. So preparation, I mean, we say prep. I sort of think of it as this entire process starts the minute you walk out and you greet them in the waiting room
Yeah.
and shake their hand and bring them in, because they're already seeing both of you presented together side by side. Something's up. There's two therapists here. You're introducing yourselves. You bring them in, even if it starts off very light and a bit of a meet and greet. And what are your hopes here? I see it as it's already begun. We're already starting to create this frame and develop this process and sort of unearth some expectations here. So the preparation phase, that's really a number of sessions that occur before dose day. And I think there are a couple of goals that really want to be hit here. It's everything that happens prior to the psychedelic experience. So both on this like personal and this like intrapsychic level, before any interventions are taken out. It's encompasses the process of screening, the selection process, trying to figure out who is the right person to undertake this treatment. If there are any red flags that might exclude them, or anything that makes us think, oh, they may not be a great candidate for this experience. It involves, just like I think all psychotherapy, like a sort of orientation to the process, making it really crystal clear, a timeline, what's going to happen, and what they might expect from this. We try not to go too deep into it, and we try and actually, I think, try and get people not to read too much themselves, because you never know what's going to happen. We never know what's going to happen. And we want to try and minimize certain expectations that they might have. So it's both a period of sort of assessment, but also where we're subtly trying to orient them to having the right sort of frame of mind for this experience, which is really one of trying not to have too rigid of an expectation of what this is going to provide for them, and sort of tilt them towards more of an openness and a curiosity about what could come up. Because we go through like some particular tools or techniques that could be useful, some breathing techniques they might do, or ways to ground themselves, what to do if they're facing something that's really confronting, giving them a couple of tools that they can draw upon to get through a challenging experience. So all of this is in a way to, orient them towards this certain mindset, I suppose, which I think is deliberate. I don't think that that's affecting or sort of having an undue influence at all. I think that's actually a very thoughtful and deliberate thing that we try and do for them, to influence them in this way. On top of that, there's a lot of the logistics of the day. So talking about making sure you're well rested the night before, having a solid breakfast before coming in, having a loved one drop you off in the morning and being available to pick you up. How are we going to navigate things like bathroom breaks? How do we come out of the experience and go to the bathroom, and who's going to take you by the hand? All of that thing. We go through, I guess, one of the things that's unique about psychedelic assisted psychotherapy, which really was, there's this idea of supportive touch with consent, which really, I mean, if I know anything about psychotherapy, it has been, we don't touch, we use our words.
Yeah.
And this is, throw that out the window. In fact, don't use your words in a dose day. That's incredibly disruptive to the process. Just use supportive touch. That's consensual and sought out by the participant. So I sort of had to get over that discomfort myself, and learn to be okay with that. And negotiating these sort of boundaries and telling them, like, this is where we'll be. We will not intrude on your space. We'll be here and available for anything that you need. Just making everything like absolutely crystal clear, because as you can imagine, this is an incredibly vulnerable experience for someone.
Absolutely.
They need to know that if things get challenging or shit hits the fan, that they can depend on us to be available and present and boundaried and respectful of them. So that's the preparation phase.
I know this may vary depending on the substance that's being administered, but do patients generally have to taper off of other psychiatric medication that they're on, or is that something that is that's something we've noticed? Sorry, this has come up in some conversations we've had with other people, where, for example, someone going to Sarah Miller, our guest who did ayahuasca in Peru for depression, also had to stop taking antidepressants for an extended period of time before that. I'm just wondering how other sort of cocktails of drugs are dealt with in this context.
Yeah, that's a good question, and I think we're learning more and more about, I suppose, what medications affect psilocybin and the potentiality of the psychedelic dose day, and how do they inhibit it, or how do they interact and things like that. Generally, I think mainly for the reason of it being something like a clinical trial, we generally get people to taper off almost all of their medications that they're on, just so it's one less variable that's involved. But for things like physical health problems, we can look at it at sort of case-by-case basis. That's why you've got someone medical on board. But generally, the antidepressants, the SSRIs and things like that, they seem to impact it in certain ways. So in the research space, it's usually, yes, we would get you to fully sort of taper off and cease and completely wean off, so it's flushed out of your system before starting.
So then I think we're up to the dose day.
Dose day.
I know you have alluded a couple of times to a phrase that's going to be familiar to many of our listeners, set and setting. And a lot of what you've been talking about in terms of preparation is about cultivating a certain kind of set. I wonder, especially as you're walking us through the dose day, if you can also talk about the setting.
Yeah, thank you. That's a good question, because I've skipped over that, and it's actually really important, because I should have mentioned all of this preparation phase, dose day, integration. This is all happening in the dose room.
Okay, that does seem important.
Yeah, it's happening in the room that the dose day is going to occur in, and it is set up like the dose day is going to occur. So we have got, usually there's some like soft lighting of salt lamps or things like that. We've got some plants. There might be a diffuser with aromatics, and we play music from a very deliberate playlist. So all of this sort of facilitates this like transitional space. Ours was beautiful because we had this tiny little hallway between our dose room and the outside world of this university and this research place. So there was actually a very clear like transitional hallway that they would go through, and then they're in this this threshold. They would go through the veil into this dose room that we would set up to be identical the same time, and we'd set it up like this is more and more like what the actual dose day will be like, sort of anchoring them in this place where certain experiences and things can happen. So we're going through that, and then we get to the dose day, which is a very exciting day. We get there very early, participants probably at about 8:30 or 9 o'clock, and we set it up. So there's a big couch, and we put down some linen, and we make it all very nice. They can have weighted blankets or bring something of their own that they feel helpful. Lots of pillows. It looks just really cozy and comfy, just like really, really nice, like this perfect little place you want to chill out in for a little while. And they can bring things that are important to them, like a soft toy or anything that sort of, has some sort of meaning, or they can hold on to, then get them through, a challenging time. In terms of like how they should prepare or what to dress, we sort of recommend like dress as though you're going on like a long haul flight. Like go for it, like hoodie, tracksuit pants, like get comfy, okay? Because we're going to be in this tiny room, and it's going to be a full day together, and it's going to be exhausting and emotional. And at the end, you feel like you've been hit by a truck and you've been on an international flight anyway. So they come in, and we prepare everything in advance. The things behind the scenes that participants don't always see is there's this like frantic rush to make sure that everything is exactly in place, that things are everywhere they need to be. The frustration of trying to get Bluetooth to connect to speakers and to headphones and things when there's 2 minutes to spare, and this like absolute rush, and they don't see any of that because they just see both of us come out and greet them in the waiting room very, hi, welcome, how are you? So there's a lot we try and conceal like behind the scenes to show that, all this frantic setting up. But then once they get there, again, we go through this sort of process or ritual. One of the things that I think is important about the dose day being the same day as the prep days and the integration days is there's this ritualized process to it. They go through a procedure that like gets them progressively towards this sort of cultivated state of mind. So we do that with the setting and how it actually looks. And then also these rehearsed sort of series of steps that we do. So we would start every session, same as dose day and prep days integration. It might be this breathing that we do together, this breathing exercise, just to orient ourselves to what are we actually doing here again? And can we all get into this frame of mind? So we go through that in the morning. Because it's a clinical trial, we'll do some things like measuring blood pressure and weight and checking that everything's all good in terms of their physical health. In the research space, we're monitoring them with the blood pressure cuff throughout the day at different intervals. And then it comes time to take the medicine. It's this like absolutely nondescript capsule of psilocybin. It looks like nothing. You can imagine anything, and we, hand it over to them and invite them to start the process. And for the dose day, it's a very internal experience. So even though we've got the room set up to be nice, they don't spend a lot of time being present or looking at things that are in the room, because they're actually got these like blackout eye masks on the entire time this is happening. Once they've ingested the substance and they lay back down, they've got these eye masks on that completely occlude all light. And then they've got noise cancelling headphones on. And they're lying down on this couch, and that's the next 8 to 10 hours while we play music from a deliberately curated playlist to sort of guide them through their journey. And that's dose day. And you've got myself and co-therapist, and we're in 2 chairs sitting directly opposite them, and we're attending to any need that they have. If they need to take their eye mask off and they need to go to the toilet, one of us guides them there. And our job is to attend to their needs and be really, really mindful of them and not interrupt the process. And if they're finding it too hard and they need to come out, or if we feel that they're spending a bit too much time outside of this internal process and they're taking the eye mask off and the headphones, we try and wonder out loud with them what's going on. But it's really about trying to reorient them back to what can we do to get you to go back in. You know, what mantras do we need to practice together of like trust, let go, be open, in and through, whatever we need, whatever helps you go back and get through this.
To the extent that there is any conversation that happens in these sessions, if the patient says something or has some sort of insight or produces something, however vatic, does it get written down or recorded, or does it? I think about those sort of insights that can happen to a person when they're having a psychedelic experience, and then you get so close to the ineffable and you want to say it, and then maybe it won't seem so ineffable later, but you want to have it recorded somehow. Is that part of your role in this?
It is, and it's to just give them the material or whatever they need for them to get something down that's important for them. So generally that's towards the end of the day when they're coming out after about 8 or 9 hours. We make sure that there's like some writing material, some paper and some markers and some drawing things, whatever they need just to write things down. And we give them all the time that they need and really encourage them to do that. I think we try and steer away from discussing or any sort of meaning making at that point.
Yeah.
We try and save that for integration. You know, people will come out and be like, I have this sudden understanding of all these things. I've just realized. It's like, okay, great. Like, let's sort of try and sit with it, save it. We're still making the most of this day. If something's important to you, why don't you record it or write it down in some way for now? And we've seen people come out and write things down or make, you know, beautiful artwork and little mandalas and things like that, which is really cool. Yeah.
So if people are verbalizing, they have a chance to record it, but it's not that you are in that moment on dose day. You're not having a back and forth with them. This is where, if I'm understanding you correctly, what you were saying is sort of your impulse because of your previous training might be to talk, but this is where something more like supportive touch or otherwise maintaining a kind of containing environment is more of the role. Is that right?
Yeah. Or to reorient them to continue to think about what they've experienced or to continue to have that experience while that drug is still very much in their system. Let's not try and, I guess it's like, I don't want to prematurely cut something off or constrict it by trying to impose some sort of shared understanding or meaning making at that stage.
Yeah.
Like that would sort of artificially constrain something that could be potential, I feel.
Yeah, it would curtail what's happening. That makes a lot of sense.
Even if they're desperate to say a lot of things. So try and be very non-directive and like, like you can say anything like that's, but we'll save the thinking about it together. We'll save that for our integration, which is the next day.
And so what does that next day look like?
Next day integration, that's what I think of as like the psychotherapy component of it. which is sort of a bit different from classical psychotherapy. After we've sent this person home and we've done some education with their loved one, which is important to happen because, people are really invested in people's recovery and they've had this exciting day, and people come out of it feeling quite emotional and a bit fragile, and their loved ones, all the best intentions, they pick them up and they're driving them home, and they just can't help but turn around and be like, so how was it? What was it like? And we try and be like, let's try not to do they're a bit fragile that night of, we recommend like they just take care of themselves, have some tea, have a hot bath, have a early night. They usually sleep really well after a big dose day. And if they have any thoughts or anything that come to mind that seem pertinent, or any dreams, like write that down and we'll chat tomorrow. And the next day we do integration, and the integration is in the same room as the dose day, the same room where it all happened, with the same low lighting and the same playlist happening in the background, which I think is great. And the task there is, I think the task there, I've had to learn a bit and change my mind over time about what integration is. Is it psychotherapy? Is it not? I'm still not entirely sure, but from what I've arrived at, it's, I think, as you were saying, Patrick, like you have this experience of something that's like beyond words and ineffable, and it's so elusive and it can like slip through your fingers, these important realizations you've had. I think of it as like the task of integration is, how do we get them to hold on to something? How do we get them to hold on to the evidence that this emotional, overwhelming, intense day happened and was very real, and that they can carry something with them as evidence and testament to that. So I try and keep it very non-directive and very, I'm mindful about the level of suggestibility that they're under and me imposing a certain like view or interpretation on things. I try and avoid any sort of interpretation, but just try and get them to recount and recollect and talk about the experience and what they found important, and use their language and their words about what it is that was significant for them. If they use words, sometimes the integration is them just sharing their drawings and what's important about it, or using that time to do more writing and more artwork, and getting them to tell me about it as they're doing it.
Everything you're saying is so provocative and interesting, and I think many people in our audience will respond the same way to this. And something I find myself thinking about here is about differences in degree versus sort of differences in kind, vis-a-vis like the model of a classical analytic encounter, right? Where there is, in the classical Freudian mode, at least, your eyes are somewhat closed, you're in a supine state, right? You are free associating in this kind of, demi-dream world. You're just sort of saying things, and then there's this, the interpretation and resolution of resistance, I guess, that happens from that. Clearly, that's not what happens on dose day, nor does it quite seem to be what happens in the integration day. And yet also it does somehow seem contiguous in some way I can't quite put to words, in the sense that the patient or the person who's experiencing the therapy has a very internal, I guess, interior, but fundamentally contained and accommodated experience of not just like association, but just of like some kind of, let's call it imminence, for want of it. I don't know. They have something comes at them. A lot of things happen. And then subsequent to that, rather than like a very directive I don't know, like an analysis of transference. Like, when you saw this thing during the midst of your experience, that was me, your analyst representing this person. And like, it's not one to one in that way, but in spirit, or at least in terms, again, that I find hard to put to words, it seems to be about a sort of constructive meaning making sort of recognition process.
Maybe I can just throw a few other words in there too, Patrick, is that I feel like part of what you're describing that feels analogous with, let's say, like psychodynamic therapy, is that there's a coming apart and a putting yourself together. Does that respond to some of what you're saying?
But with it also in the sense that, and I'm thinking about this in terms of what Josh, you said about like the way this quickens or almost pressurizes certain types of things. So much of psychotherapy, and I love it or hate it, but I think this is true, is that sometimes your therapist is saying the same thing over and over to you many different times.
Many different ways.
And eventually, at some point, you're like, you realize it for yourself, or like someone else says it, and you're like, whereas this is so much more, both in terms of like time and intensity and your availability, even on the dose day. It's not, I mean, we'll talk about like the practical challenges. I'm trying to imagine the American healthcare system being like, you're going to get 2 clinicians for a 12-hour trip. But even in the middle of that, you're there, right? Your presence is containing. And again, I don't know if I want to talk about this in terms of like mentalizing or whatever the self is, to use Abby's language, that's been taken apart or that's come apart and gets put back together. That's a different, there's something more radical possible there, or the change in self is a little bit more different than the kind of like incremental, okay, we're just going to keep on reminding you that maybe you don't have to have the same relationships over and over again. And eventually that'll click.
Yes. That's a really good point. And I think what I've seen is, and what's often quoted from participants and what I've heard is, it's like getting 10 to 20 years of therapy in one hit, or it's like drinking out of a fire hydrant in terms of a therapy dose. There's something really intense about it that is like this highly concentrated form that a lot of things happen in a relatively brief amount of time. And it happens internally without a dialogue between me and the participant, and a lot of the times without me being aware of what they're going through inside.
Yeah.
And what we see on dose day is, because you're in this like altered state, there's something about that allows people to look at these parts of themselves that were dark or unbearable or unwanted, and they can look at that with some sort of an embrace or a kindness or a compassion that they would not be able to access or do unless they had the trust and the safety of a well-established and deep therapeutic relationship with someone. They would not be able to get there in another way. And because they can do that, there's something there. They can also, have conversations with like figures from their past that have really troubled them on dose day, and feel like they've achieved some sort of a resolution or seen things from a different sort of perspective. I think what we haven't spoken about is like the experience for the participants, like this sort of ego dissolution, or just that experience of seeing things from another sort of perspective, or how constricting their worldview has been up until that point, and being removed from it and seeing it from afar, that gives them this whole new sort of lease. It completely changes how, the opportunities that they see moving forward. They can do things differently. They can see and feel things in a different way. And so much of this I'm we are completely don't have access to on dose day. This is
Yeah.
happening to them. So I try and think like what's the thing that we can do to facilitate something like this. And I think, through supervision and working with my co-therapists, it's just come down to there are things that we can do that are so small throughout the day that don't interrupt their experience, but also provide that really kind and interested containing function. Small things like if they go to the bathroom and they've got their favorite little jumper or hoodie and they leave the bed and the blankets are all askew, while one of them is taking them to the bathroom, I'll neaten and make the bed really nice again and just fold it up and put all their things really close to them. I'll make sure that like what they have brought that is important to them is in like a really protected and nice space. And just little things that can signal like that degree of interest in them. I think like, because that's all you've got. I can't use my words in the dose day. I can't give reassurance if they don't ask for supportive touch, but I can demonstrate that I'm holding them in mind and I'm attending to them.
I'm going to ask you a question that's so quotidian compared to what you were just talking about. And if you can't answer it, no worries. But since we're talking about ego dissolution, how much of a dose are you giving?
Massive.
Massive. Like, can you actually tell me?
Yeah. We were giving, and this is a pretty common sort of therapeutic dose in these trials. We're giving 25 milligrams of psilocybin, the compound, the active molecule of psilocybin. 25 milligrams.
That's a lot of psilocybin.
That's a lot of psilocybin.
Yep.
Okay. All right. That helps kind of.
Yeah.
Just wow. I have to sit with that for a little bit. I want to shift gears and ask you a little bit, Josh, about the legal and ethical issues involved in psychedelic assisted psychotherapy. So I have a couple of questions here. I mean, first of all, what is the legal landscape like in Australia, and how has that affected your work? And also, I'm thinking about this having seen some of the work that you've done. What are some of the ethical issues that you find most pressing? I mean, so I'm thinking about, just to give a few examples, what it means to work with individual patients in this modality, given just how vulnerable people are under the influence of a drug that's not only really powerful, but it's also, particularly characterized by suggestibility. I'm thinking also about the concerns, which we've already touched on a little bit, about taking psychedelic experiences out of indigenous cultural contexts and settings, as well as the desire, I think, that some people have for psychedelic psychotherapy to become this kind of quick fix, right? Partly because it does have so much potential to be, as you put it, something like, 20 years of therapy condensed into a couple of days. But yeah, I'd love to hear you speak to those kinds of issues.
Yeah, I've got a lot of thoughts on this. It's been really strange. It's been really strange in Australia. We're in a unique position where we had these medicines rescheduled. All of a sudden, there were a lot of headlines, as these trials were starting. It just happened to coincide. Actually, it wasn't like related, but psilocybin was always scheduled. We call it a Schedule 9 medicine, which is basically a poison or an illicit substance that has no therapeutic benefit and cannot be prescribed or safely used. So that's how it's always been since, I guess, around the 70s or 80s, a Schedule 9, like reasonably so, a highly controlled substance, no therapeutic benefit. And any trial that was being done on it was in applying for the government to test out the safety of one of these Schedule 9 medicines. And you'd have to apply to use it because you're doing research, you're doing a trial on something that's unproven. And in 2020, it had come up for review. I think it was just like a certain amount of time had elapsed. And a lot of people had given some new and emerging evidence to the Therapeutic Goods Administration in Australia, our TGA, it's your equivalent of the FDA, saying, we're getting a lot of really, really interesting data coming out of America, coming out of UK. Like these medicines are being studied now, and they seem to show promise for certain conditions like depression and PTSD and things. And the numbers in the trial have been small, but very promising. And that was submitted to the TGA, and their response was, yeah, these early trials are really promising. But you basically need more evidence. Like if you're going to say we can prescribe this as we do fluoxetine or one of the SSRIs,
Yeah.
you got to step up. You got to show more numbers and more safety. We need long-term outcomes. And I think everyone sort of thought that was sort of fair enough and sort of quite judicious and safe. But what was happening in the background was we were starting to get some big lobbying groups occur. And they were pushing for more access to these, life-saving medicines for treatment-resistant causes. So when this decision was made, it was met with a lot of public pressure and some really strong lobbying, like, please reconsider. And they commissioned this report from some independent experts. And I think what blindsided all of us was that, yeah, they got to the same conclusion. There was no new evidence that they were provided. And even the people that were working in the clinical trial space were saying this is really promising, but it would be premature to say, hey, open the floodgates, let's prescribe it.
Right.
And then all of a sudden in July 2023 in Australia, we get it downscheduled. It becomes a Schedule 8, which means authorized prescribers can offer this for certain conditions, sort of against the recommendations of people that were actually working in this space and doing these trials. I think the problem is, it caught everyone off guard. And, how can we possibly meet this demand? I mean, I've spoken a bit about what's involved in psychedelic therapy. You need two clinicians, dose day, that's 10 hours or so of their time. And that's just dose day. You've got the prep, you've got all the integration. You're talking about like 40 hours or so per clinician of their time for one treatment for one person. How on earth are you going to train up enough of these people to do this work, to meet the demand of people wanting scripts for psilocybin for their treatment-resistant depression, when it clearly is more than just a script that you need to provide for them? So I think there was a lot of concern and confusion and worry about how is this going to actually affect it. To date, I think we've got like 35 authorized prescribers in Australia over the past 2 years. It's really not something that's everyone can do, even the ones that are authorized to do it.
I mean, what you're describing also sounds incredibly emotionally intense, not just for the person undergoing the therapy, but for the dyad of therapists who are doing this preparation and containing and helping integrate.
Exactly. It's a huge day for the person, the participant, and their loved ones. They have to do a lot of work, and it's hard for the therapists. It's exhausting. I've spoken to Justin Dwyer and Mark Ross since. They were the ones that did the first trial in Australia, and they've trained me and given supervision, and they're authorized to do this work.
Mm-hmm.
But talking to them about what's feasible, maybe one a month, like any more than that is just, I mean, it's really difficult work to do, even if you were compensated for all of the clinician time, which is another, huge issue. Like, how much is this going to cost? An hour a week with my therapist costs enough. Like, what about 40 hours from two different therapists? Like, we're talking like tens of thousands of dollars here for one course of one treatment for one person, and the time commitment from the therapist. So yeah, so that sort of, I don't know, that's sort of like the context of what happened in Australia, and,
Yeah.
I'm in these weird two minds about it, where it's like I feel a bit icky and gross about the lobbying that occurred in the background here, and I'm not sure if that's how medications should be deemed safe by public demand, like, or should a more rigorous process be occurred? But then, if that hadn't have happened, would that have generated the discussion and the interest and the discourse that would have allowed me to do this sort of work in these clinical trials? Would they have gone through without that hype surrounding it? Yeah, I'm not sure about that.
There seem to be these trade-offs, and I could almost imagine like an actuary or some sort of numbers person calculating them between like, well, if we can get, you know, the equivalent of 5 years of therapy through yay many sessions, then the billable hours accrue, you know, less the malpractice insurance that presumably would be very substantial with trip sitting. But then the thing that is sort of intrusively entering my mind right now about the US context, where I imagine also, as in, you know, Australia, people are doing this informally. Like, I'm sure there are people who are, you know, growing their own things and doing this type of stuff without any quality control, and that's a problem in its own right. But here in the US, if we were to have this as a type of treatment that was, you know, more publicly available, independent of the things we have to change with federal law, we'd have advertisements for it on TV. And I'm just trying to imagine the talk to your doctor about during the Super Bowl. Like you need to feel one with the universe, right? And oh my God, it would.
There's like a giant mushroom and like Hugh Jackman is on top of it and everything starts melting and it's in the middle of the Super Bowl. Yeah, that's depressing, Patrick.
Well, but what I'm thinking about here too, and maybe this gets at something we were talking about very much in the beginning, right? Is that this is a bleeding edge example of how care has to be holistic and involves a whole range of supporting mechanisms. And, you know, not knocking the efficacy of people who are, you know, getting a antidepressant from their GP and they're taking it every day. And well, that's fine. You know, like there are many such cases in this country, at least, but that particularly for things as powerful as this, but presumably what this just again highlights is a case in point of a broader principle. You need to have institutions and people who are willing to provide support and context for open-ended and potentially distressing, but also transformative experiences in a profoundly relational kind of way, and also to produce these sort of like a human ecology of producers and carers, and it's definitely not about the bottom line, right? Or whatever the bottom line is not the same thing as that.
Yeah, I it's kind of like this land grab, like this territory of who can rush in and deliver this treatment. And you see a lot of companies or private organizations wanting to sort of have it all. It's not just be the ones that deliver the treatment, but also deliver the training and hold the intellectual property of the medicine to own as much of the space as possible. And I just sit like, at least from my experience, I don't see how it can scale like to this size that can be profitable. Like even the ones that do this work, and it takes a toll. Like it really is exhausting. It's like 10 to 20 years of therapy for the participant. It's like 10 to 20 years of therapy for the therapist as well. It's really hard work. And to make it, you know, at all profitable, you know, these degrees of scale, it worries me about the aspirations of some of the, I guess, the investors in this space.
My sense is that you're also worried about the vulnerability of the patient, right? I know you alluded before to that being one of the primary reasons for there being two therapists. I wonder if you could tell us a little bit more about that.
I think that's important as well. I share this thought with a few other people that work in this space, and I feel really lucky that I was invited to attend the training with Justin and Marg to do this work, and they didn't do an open call of who would like to become a psychedelic assisted psychotherapist. They reached out to people that are already well-established therapists that are good in their own right at treating these complex conditions, and then invited those ones to relearn or unlearn some certain things about how to work in this new territory, because they have this like foundational training and principles to work on. And I think it's just really important that you get people with expertise that are skilled, that can deal with sitting with difficult experiences and new and unknown territory and emotional challenges that come up, where they do have to hold a certain position at all times and not get swept up in it. Like I said, the person in the room on dose day, they're taking the drug. We're not, as therapists. But you get swept up. It's intoxicating, like that environment, and trying to hold on to the fact that, oh wait, no, I'm a therapist right now. Like I have one foot here and I'm attending to your needs and their supportive touch. Like you're going to lose the boundaries. You can do that. That's fine, but I can't. And I think that's so important. And, there's huge amounts of risk. Like these, people are entirely vulnerable during dosing. We know that there's this loss of self-blurring boundaries. There's this completely, the as if or the symbolic function gets thrown out the window.
Mm-hmm.
You are not as if it's your mother or father. You are the mother or father because you're messing with what they perceive and who they misidentify. There's increased suggestibility, which is more something that I consider in the integration phase. Like, what sort of framework am I imposing here that's telling you to make sense of this experience? But you can imagine someone being a bit opportunistic in a dose day with someone that vulnerable.
Yeah.
This idea of like, supportive touch and informed consent, like negotiating that process beforehand and thinking, well, what if on dose day they're like, all up until they're like, oh no, not for me, thanks. I'm not a touchy-feely sort of person. Then on dose days, suddenly they do, and they want to hug, and that would be really healing for them, but hasn't been explicitly consented to beforehand. Like, is that valid? I think all of this is just there's significant potentials for like massive abuses of power to occur. And unfortunately, we have seen that in the past. There have been, trials, I think some in Canada, where they're using MDMA for PTSD. And one of the therapists there decided it would be really healing for this woman that's going through this re-traumatizing experience to lie on the bed with her and like give her this like protective, nurturing cuddle. And it's just, really, really scary stuff that can go wrong.
And we enter into a lot of territorial overlap there with things that have happened in like new religious movements or various sort of like, plastic Indian shamanist style sort of situations where you both have these powerful substances, you have the element of ritual, but then you also have the kind of narcissistic inflation that even the best meaning sort of like guru or would-be caregiver just has. Like people are experiencing ego death because of me in front of me. And I am delivering 10 years of therapy in this condensed moment. And I don't know, I confess here, and this is just something that I have thought about in relation to other medications too, right? But that I think this is a case in point. This may be like the example that proves the rule about the need for these other structures or some sort of relational orientation. But I've met a couple psychiatrists who have differing opinions on the like, not just like the wounded healer trope or something, but have had reasons to try or have gone out of their way to try the medications that they prescribe, right? Insofar as that they, and again, I'm not naming names, I'm just thinking people are like, well, I should know what happens to a person. I think presumably there's some blinders on this because things take months, but like on some inchoate level, part of me also feels like if you're going to be, I don't know, like filling someone with like several hundred milligrams of Seroquel in a prison or something like that, you probably should be much, at the very least, cops tase one another as part of their training. That doesn't go very well as an analogy or even as a thing that they do. But I do think that there's something to be said for trying to bridge the first person, third person gap when it comes to some of these things, at least being like able, like, this is going to knock someone out, right? Or this is what it actually does feel like to be helpless in the midst of a bad trip. Like that seems to be something that could be important. I don't know why I'm reaching for that specifically with drugs of this particular kind as opposed to other ones. And yet also it does seem to strike at this question of like vulnerability.
Patrick, you've come up against something which is the elephant in the room for everyone.
Yeah.
When I talk about this, it gets asked of me by psychiatrists when I'm talking among peers. It gets asked of me from every single participant. And what it comes to is, in all of this discussion, they get to, have you done psychedelics? Right? And it's sort of like, yeah, bridging that first person to third person, like that sort of shared experience. I think what's underneath that is like, how can I trust what you're saying and trust that you'll care for me in this certain state unless I know that you've been to that place yourself and could anticipate my needs that way. So this is a really difficult question to try and answer it. And I've tried to think about it quite a bit because it can go one of two ways, really. Yes, I have, or no, I haven't. I think it's important that everyone develops their own answer to this question. Despite how I look and everything about me, I'm not experienced in any psychedelics myself personally. But so I've had to come up with my own sort of answer of like, no, I haven't, but I'm really interested in trying to find things that work for people that we don't have a lot of treatment options for. And I'm, skilled in therapy and I'd like to think that I can be there in your hour of need and I can demonstrate that. And I try and do that through how I act rather than how I try and sell it as, you can trust me. I try and do it in the orientation and the preparation phase to establish trust rather than tell them they can trust me.
It seems in that way to be a continuation of this almost irresolvable problem of like the difference between degree and difference of kind. Because at least in some ways, and classical psychoanalysis is the great example of this, right? You can trust that your analyst has been through a training analysis, right? So if you're going to regress, if you're going to have a transference neurosis, if you're going to have an enactment as a patient, some part of you at least can do so with the safety or like the awareness, conscious or otherwise, that at least as far as the brand of credentializing is concerned, your analyst has been on the receiving end or the experiencing end of that type of transferential experience.
Yeah.
And clearly, for so many reasons, that can't necessarily work here, not least of which that these substances are illegal in many cases, and thus the clinician would have to be divulging something that could be very problematic and for all sorts of reasons in and outside the setting. I guess one way to maybe pull back and square the circle yet again, right, is how talking about psychedelic-assisted psychotherapy really underscores the fact that everybody, and not just clinicians, but like we seem to get very few opportunities just in general in life to come apart in kind of radical ways and just literally be, I'm trying to imagine like the last time or how frequently a person like you get to come apart for a day and just be in yourself in a safe place and literally it's moving to me. You'll make the bed when they get up because they have to go be sick. Right.
Patrick almost cried when he said that.
Beautiful.
No joke. I was like, are you going to be okay? Do we need to stop the recording?
It's beautiful.
Like
we just don't
fold
get
their
that.
jumper back again, like rearrange their headphones so it's right where they need it, like put their water bottle closer, like their phone on charge, like all these things that they can return to and be like, oh, someone is caring for me. They're thinking of me when I need that.
Josh, before we go, can I ask you to engage in some informed speculation?
Sure.
I am really interested in your thoughts on the future of psychedelic assisted psychotherapy in general, but your greatest hopes, your greatest fears. What do you think?
I really hope that we can continue to do this research and that more opportunities for these trials come out. I think the early results are really promising, and I want to see more evidence. I really hope that we get answers to some questions that have sort of been where it's come under criticism. The reality is there's a lot we don't actually know. This isn't something that's going to be this panacea for everyone and all forms of mental distress. We need to be more informed so we have the authority that we can tell people. We have a pretty good idea now of who it will work for, how long it will work for, what works best for which conditions, for which patient. Like we shouldn't really be offering it as a treatment until we can share all of that, because otherwise people can't really make an informed decision about whether it's right for them. And at this early stage, I don't yet have a sense, like being on the ground floor, like we're not sure who it works for, really, considering the expense as well. Like if you're going to sink 30 or 40 grand into this treatment, like, maybe we should be able to determine in advance who is most likely to benefit from this, for one. So I really hope that the studies that we're doing, the trials that we're doing, that they're done in this methodologically rigorous way, that hold up to scrutiny, that are watertight, that are very transparent about all the outcomes, positive and negative, and that we can accumulate more and more of this to get more information and informed policy and access. That's like my biggest hope, that we see that. And I think my fears are sort of what I start to see already. So, coming back to, the dark origins of something like psilocybin and Maria Sabina, this idea of it being completely ripped from its spiritual and cultural origins, and as this source of wisdom and healing as a traditional sort of plant or mushroom-based medicine in other communities, and we sort of take it and strip it of any sort of association or connection with that. Like we're sort of taking this accumulated knowledge over millennia and then sort of talking about as if it's like this discovery. And I think there's a chance to do some intensely damaging, like, harm here to relationships with indigenous communities again. And I think just the scalability and this idea of it being this pill that we can mass produce and market. I think one of my, I'll share a small thing that I thought was really unfortunate. And it was that, this big trial that I initially trained for, where all of us did, it was going to be all across all these sites, that's on hold. That was going to be started about 2 years ago, and that's been on pause. And the reason is it comes down to contracts and intellectual property and who actually owns this molecule and this formulation and what percentage of, profits and how much is going to be made and things like that. And there was like a real deep sadness in me that happened that way, that it came down to like contractual disputes and issues about who owns this certain thing. Yeah. And I think a few things that I just start to see, I swear it's like, this is like this weird dystopic future. I saw I think it was like a YouTube channel I subscribed to of something about productivity, and someone's talking about how they recently went on an ayahuasca trip, and they've realized that, the importance after they got in touch with their inner healer and their inner child, that it's all about connection, and there was this great unity with all the universe. And that's why they're now offering 50% off their using AI to maximize SEO course. And it's like, is that where we're at? Is that what we're using this for? I don't know. It felt gross in a way. So I hope that there's more respect for these medicines, for the potential of them, and that there's some recognition of the profound debt that we owe a lot of cultures across the world, and don't erase their contributions, but bring them, like, give them a seat at the table here. I think that's how we do it right, not just from the methodology of it all, but I think that is also how we go about this in the right way.
Josh, thank you so much. This has been really just so incredibly illuminating. I know you've been thinking about this conversation for a really long time.
No, thank you so much for having me.
This was amazing, honestly. I wish we could take much more advantage of your time if we don't want to, particularly on a Saturday morning.
Thank you so much for joining us for this episode of Ordinary Unhappiness. Ordinary Unhappiness is completely made possible and kept ad-free for everyone by the generous support of our Patreon community. If you'd like to support the show and get 2 additional Patreon episodes per month, please head on over to patreon.com/ordinaryunhappiness. This has been an episode of Ordinary Unhappiness, a podcast about psychoanalysis, politics, pop culture, and the ways we suffer now. I'm Abby Kluchin, and today I was joined by Patrick Blanchfield and Josh West. This podcast is produced by Dan Yowell. Theme music by Formal Chicken.